blast through these, but if I'm going too fast, let me know, because some of this, the basic characterization is a review. And yeah, big thanks to Hugo Paz for developing these slides. He was a Palm critical care and sleep guy who was here 2-3 years ago, something like that.
That was the reason I came here.
No way, because he was at the clinic before.
He was when I did my first ICU as an intern with my fellow licensed driver.
Yeah, brilliant. Brilliant guys. He's in California now, and I've mercilessly stolen his slides. So here we go. Okay. Is it not advancing? Okay. All right. History. First described in 1985 as a clinical entity. There had been descriptions, 20 years prior to that by Jouvet, actually, in the mid-60s, in cats who sustained a pontine lesion. He noticed that they would act out their dreams, but took 20 years to describe that syndrome. There were then 4 criteria developed in the early 80s for RBD behavior, depending on the site of the lesion, which determined, importantly, that losing REM tone is insufficient, necessary, but not sufficient to generate RBD. You also have to have disinhibition of motor pattern generators, the sort of central pattern generators. So it's a mix of activation and deactivation, inhibition and disinhibition. But all of these processes have a shared upstream neurophysiologic sort of controller, which we'll talk about. And that's the proposed mechanism. Okay, clinical features. The hallmark is vigorous or violent motor activity occurring in REM, obviously. Usually there is, vivid, unpleasant dreaming. Typically, these are self-defense dreams or escape dreams, and the activities that you see are self-defense or escape things. Very rarely are they, as shown here, carving up a melon or something. That would be awfully benign. Yeah, common theme of being attacked or chased by unfamiliar things. Primary emotion experienced is fear. This is not an aggressive kind of thing that can look that way. Because this is a REM phenomenon, if they're awoken during the event, they have dream recall, they're alert, and able to tell you what they were experiencing, unlike non-REM parasomnias. Okay, video time. So right away, this guy's in REM and moving way more than he should. That kind of locomotor activity. Snapping. For good measure. Pardon? He tuckered himself out, yeah. So I don't know what it is about these videos, but every patient looks about like 90 years old and like super frail.
Yeah,
and, yeah. I don't think he is, but anywho. So interestingly, 86, a year after the clinical description of this. Back to the beginning. Anyway, so a couple of important things to point out here. So we don't see the EG, but he started off in REM sleep. You may have some sort of small motor movements, usually kind of finger flexion, that kind of thing would be typical and normal in that, but the amount of hand and arm and leg movement that he was having is definitely abnormal. And that is part of criteria for diagnosing RBD, but the actual, behavioral event happened about halfway through. Started kicking, rolled over, smacking the bed. Okay. Contrast that to those two non-REM parasomnias we saw, the woman kind of ducking to cover her head, the guy leaping out of bed. I mean, those lasted all of 1 second, the actual motor component, and they were confused for like a minute after. This guy had a long build-up to it with protracted, agitated motor movements, slapping, kicking, slapping several times, that kind of thing. Not a one and done kind of phenomenon. Again, is that pathognomonic? No, but can it help you differentiate between the two? Yes. RBD is rare, gets more prevalent with age, especially in the elderly, but still only affects maybe about 2–3%. Typically seen in middle-aged and older males, 40 to 70s, although it can affect women as well. Typically appears in the second half of the sleep period, as we would expect from a REM phenomenon. And all kinds of behaviors have been described depending on what the dream material is, but your classic would be some kind of self-defense behavior. So that one's tricky because that one looks more like the non-REM parasomnias.
Yeah,
that we saw, right?
brief.
Could you distinguish, this based just on this video? No.
I mean, you could maybe argue that there seemed to be something purposeful there, but it's too short to.
But too short to know. Yeah. So this is where it gets tricky. The semiology isn't everything. Let's look at another example. This one's maybe a little more. Kicking, sort of purposeful, sustained, not long, but a little longer than we saw in the non-parasomnia.
It started themselves out of dream state.
They can, yeah.
On one side, that our dreams are quite contracted in that time. Like,
Yeah.
in our brain,
Yeah.
our dream may seem like an hour,
Yeah.
song, but really it comprises of like a 10-second
Yeah.
thing.
Well, that's the whole point behind Inception, right?
Right.
Yeah.
So,
Great
Going to
movie.
the theory of relativity here.
Yeah.
what I'm saying, so are these kicking and fighting? Are they the duration of the dream?
We don't know. No, that's a great question. Are these whole dreams and from start to finish? Are these dream fragments? Most people describe some buildup to it, but that's not universal. No, it's a great
The
question.
only thing I'll say about that is I remember this happening sometimes, that if you're being woken up and you're dreaming, then that waking up influences that last part of the dream, which I feel like is pretty much not a very long time.
Yeah.
Like, for example, my wife woke me up and I remember I was dreaming, but my dream there was an earthquake, and that it was like probably 10 seconds. And
That's my alarm going off. My alarm can be like a gunshot or something.
yeah.
But this, 10 seconds of this turns into 15 minutes of an earthquake. Yeah. Yeah. Okay. So this is a concept we've explored before, but long story short, there are overlapping sleep states thought to represent differential cortical activity in different areas of the brain. And I think, yeah, here it is. The best example I've seen of this actually comes from intracranial EEG recording. So this is somebody who was undergoing planning for epilepsy surgery, but what you're looking at here is intracranial stereotactic EEG lead, so the labeling is all wonky. But the key point here is that in the kind of frontoparietal regions here, you've got what appears to be slow wave sleep, almost rhythmic kind of delta at the onset of the confusional arousal. Whereas in the more central areas, motor cortex, you have this sort of buzz of fast, almost awake-like activity. You're very unlikely to be able to differentiate those two things with scalp recording. But that differential expression is probably what's going on in most cases. Now, this is not a totally normal, healthy brain. Exhibit A for the non-neurologists in the group. So those are spike wave discharges, I mean, this is, which are very frequent. And we don't see the end of this. That could be a seizure. I'm going to tell you it's not, based on what this guy's seizures look like electrographically, but we're only seeing a snippet, and that's not enough to say. But anyway, that's kind of not the point. The point is that there's sort of differential baseline or background activity depending on the brain region. And we think that's why parasomnias happen. Okay. You have probably heard about an association between RBD and neurodegenerative disorders, and it's an important part of our practice because it influences how we advise patients if we're coming to this diagnosis for them. But important point, in young people, and I would go so far as to say in most people, in all comers, secondary RBD is most common. It's from meds, typically antidepressants. Or it's pseudo RBD from obstructive sleep apnea that's not treated. But in older people, primary RBD becomes more prevalent, and it's the primary RBD that has an association with neurodegenerative disorders, not the secondary RBD.
So even though antidepressants are generally REM suppressants, that RBD.
Mm-hmm. Yeah. Yep. Now, some of the strongly REM suppressing medications like SNRIs should have less of that effect. But SSRIs, the mostly serotonin ones, less REM suppressing and can use this. Okay, there's also an important association between Rbd and narcolepsy. So about half of people with narcolepsy have RBD as well. But the reverse is not true. Half of people with RBD do not have narcolepsy. Most don't. In fact, only 13% of RBD cases in one study had narcolepsy. In older patients, especially those with primary RBD, the most common association is with the alpha-synucleinopathies, Parkinson's disease, Lewy body dementia, the Parkinson's spectrum, that kind of a thing. And these all share a common pathological lesion in the pons and elsewhere in important areas that control REM sleep. Shown here, RBD is common in these neurodegenerative conditions. Maybe half of people with Parkinson's, the vast majority of people with multisystem atrophy, and the majority of people with Lewy body dementia. The RBD usually precedes the development of these symptoms, the neurodegenerative symptoms, sometimes by a very long time, a decade and a half, sometimes two. And so it becomes really important that if you have somebody in whom you suspect primary RBD, you really want to make sure that at the very least a neurologist is sort of involved in their care. They may not have any symptoms, but they need a really thorough neurologic evaluation and potentially additional testing to make sure that if or when they do develop symptoms of whatever underlying condition it is, that they're treated as promptly as possible.
I remember at the clinic in one of my early neurology patients, there was a patient who was diagnosed with CJD, and the earliest presentation as an office visit was treated as RBD, which was like 2 weeks before the full onset of partial blindness.
Rough. Yeah. So, and it's tough because, it's rare in sleep medicine that we have, conditions where we need to provide very serious counseling for something that may happen, 10, 15 years down the line. But it's an important one. I'm not going to spend too much time on this, but long story short, there are two important neurologic systems to know about with RBD. You have REM on and off neurons, which are primarily cholinergic for the REM on neurons. And you have skeletal muscle tone on and off neurons, which are primarily adrenergic, although there are other neurotransmitters involved in that as well. Long story short, there are both positive REM sustaining, where's my mouse? Positive REM sustaining feedback loops here, primarily between the sort of pontine and prepontine regions and the reticular formation, and then negative feedback loops here based mostly on serotonin and norepinephrine, which are inhibiting REM, coming from the dorsiraphe and locus ceruleus. That's all I'm going to say about that, except for this slide. Okay, so these are these are some of the neurologic or sort of neuroanatomic regions involved in loss of REM atonia. So typically these are lesions in the subdorsolateral nucleus, plus sufficient activating locomotor drive in those central pattern generators that then is resulting in decreased inhibition of the spinal motor neuron, leading to increased muscle tone. And then whenever those central pattern generators get activated, then you have the behavior. That's really all I'm going to say about that. Okay. Remember, idiopathic RBD is one to be concerned about as a precursor for neurodegeneration. And unfortunately, the numbers aren't great. About half, maybe a little more, of people with idiopathic RBD will eventually develop a neurodegenerative disorder of one kind or another, which means that 40 to 50% won't. So it's not a death sentence, but a significant fraction, perhaps even a majority of patients. Mean latency is 5 to 7 years. I'm not sure that's accurate. I think it's more like 7 to 10, but it's a period of years. Not going to belabor this slide. Anything that results in damage to the pons or those other kind of neurologic areas can cause this. CJD is a great example, and medications can certainly contribute. SSRIs and TCs being the most common. In this case, this would be secondary RBD. We rarely screen for this, but there are screening questionnaires available. But most helpful, I would say, is asking one or a combination of these two questions. Have you ever been told, or do you think yourself, that you seem to act out your dreams while you're asleep? And then give them examples. Or do you kick or hit during your sleep because you dream that you have to defend yourself? And if they're consistently saying yes to that, then you kind of go into the questioning a little bit further. Diagnostic criteria, these are important to remember. You need repeated episodes of sleep-related motor or vocal activity. You need to have behaviors documented by PSG during REM or assumed to be during REM based on clinical history, such as second half of the night, dream recall, that kind of a thing. And number 3 is probably the most important one. So RBD is the one parasomnia where you actually require a PSG for the diagnosis. So you need to have this REM sleep without atonia on the PSG in order to make it RBD. If it's not, it may be some other parasomnia, but it's not RBD. And of course, number 4, it's not something else.
So 2 and 3.
Yeah. So
kind of in different ways.
yes. So the REM sleep without atonia is the only finding that you absolutely need a PSG for, because the only way to know about REM sleep without atonia is to look at muscle tone during REM.
So it's okay if you don't catch the behavior on
Bingo.
the PSG, but as long as you have REM sleep without atonia and a clinical history suggesting.
Bingo. Exactly. If you're lucky and you catch the event and it's classic, then you're good, but it's not essential. What does REM sleep without atonia look like? This is either sustained or transient. elevation of muscle tone, limb or chin during REM sleep. And the sustained elevation is greater than half of the epoch is above the non-REM baseline. There are plenty of cases where your chin tone in REM will not be pencil thin, but the key is it has to be less than non-REM. If it's more than non-REM and for more than half of the epoch, that's sustained REM sleep without eutonia. You can also get what's called ETMA, excessive transient muscle activation or motor activity, which are transient muscle activity in the chin or the limb leads. And there are certain criteria in the schooling manual. They have to have a minimum amplitude and duration, that kind of thing, which are just things to memorize. So this is an example of sustained tone in chin. We don't have non-REM to compare, but you can see there's very clearly elevated chin tone there, as well as what looks like sustained tone here in the left leg. This was an 80-year-old guy who had violent nighttime awakenings. This would be another example. These are multiple limb leads, arms, legs, a couple of other muscle groups. And you see some combination of both tonic and phasic elevated motor activity. But not so much in the chin, some, but not a ton, more episodic in the chin. This is an example of one of my patients of pseudo RBD or pseudo REM sleep without eutonia. So you notice this is his chin tone in REM, and this is his breathing during REM, lots of hypopneas, desaturations, etc. Here he is in REM on CPAP, and there's his chin tone. It's just a thin line. Because his baseline level of arousal presumably went down. There was some level of tonic arousal that was being caused by the sleep disordered breathing.
By the sleep apnea.
By the sleep apnea, yeah. So this is pseudo REM sleep without eutonia. You can get pseudo RBD as well, which is dream enactment, but it may all be OSA. In real life, everything's OSA. Rule number one. On the boards, nothing is OSA. Rule number two. All I got. Okay, so this is another patient with sustained and transient, mostly limb activity. So this would be ETMA, with a little bit of increased chin tone as well, but primarily you're seeing it in the limbs. Zooming in, you see that there is some tonic elevation, but it's really transient motor activity that's accounting for this. Differential diagnosis, it's all the stuff you would think about. If it's a parasomnia, it could be coming out of REM, you don't know, unless you do a sleep study, unless the clinical history is very good. PLMD can look like this. It should be more rhythmic, it shouldn't be violent, but the two can be confused in sort of mild cases. In any of these nice little psychiatric things here. Very importantly, nocturnal frontal lobe epilepsy often has a flavor of RBD to it. So it tends to be highly emotive, tends to be highly motor, but tends to be stereotyped. So one of my patients, I think is kind of a great prototypical example, would always run to the window and try and open it during his seizure. Never made it out, thankfully, but that was the semiology of his seizure. So, and it can be hard to tell. So, I mean, could that have been RBD? I mean, yeah. Could that have been sleepwalking? Maybe. I mean, if it were sort of a more slow movement. But the EEG is really required to make that distinction. But NFLE is very hard to pick up because it tends to be really kind of infraorbital cortex and so on, where we don't often have leads unless you do intranasal, which is gross. Anyway, okay, treatment of RBD, and then we'll wrap it up. So two primary treatments to know about, except for the usual stuff: treat underlying sleep disorders, remove offending agents, that kind of thing. Melatonin and benzos. High dose melatonin. Hand wave through some mechanism that I don't understand very well, and I haven't found any convincing explanation for, although if you guys come across something, I'd love to see it. There seems to be potentiation of spinal motor neuron inhibition through melatonin at high doses. So you eliminate the REM sleep without atonia, you eliminate the behaviors. Typically, I'll start at a soporific dose of 3 milligrams, and work your way up every week or so, usually by 3 to 6 milligram increments. This says 6 to 12 milligrams. I'll routinely go up to 20 or 30 milligrams if needed. Obvious side effects of melatonin. And then clonazepam is sort of the more typically used benzodiazepine for RBD. Here again, the mechanism is not totally well understood. And the common dose range that I'll use anyway is a quarter of a milligram going up to 1 or 2 milligrams, titrating to effect.
When you're going up in the melatonin, would you stop when it's controlled, or would you go to a set dose?
Yeah, I'll stop once it's controlled. I've never got it controlled under 15 milligrams. The evidence says you can, and some people have. I never have. But yeah, titrate to effect.
How long does it take to get to like the 6 state?
It's usually pretty quick. Yeah, within a few days. Yeah, within a week. Long story short, there's limited evidence for other therapies, but you will read about some of these other therapies out here. Okay, our last REM parasomnia to talk about is recurrent isolated sleep paralysis. Sleep paralysis happens when you have perseverance of REM atonia after your REM switch has turned off. It's kind of the opposite of RBD, right? So the brain is waking up, muscle paralysis is still an issue. Sleep paralysis is very common in narcolepsy, but it's also very common just sort of in general. The lifetime prevalence of one sleep paralysis episode in all comers is over 10%, it might even be 20%. And sleep deprivation, schedule changes, jet lag, those are all precipitating factors. But recurrent sleep paralysis should get you thinking about narcolepsy. If they don't have any of the other symptoms, specifically sleepiness, and they have sleep paralysis that's recurrent, and it's recurrent isolated sleep paralysis. This is not common. Sleep paralysis occurs when REM atonia persists. Okay, eye movements and respiratory activity remain intact. Usually there is some unpleasant dream-like material. If they're fully awake, this is essentially a hallucination. They may be partially awake, in which case it's still in the dream, but either way, it's remembered and is usually very scary. So these are the diagnostic criteria according to ICSD-3: recurrent inability to move the trunk and all the limbs at sleep onset or upon waking up. Each episode lasts seconds to a few minutes. Minutes would be rare. Episodes cause distress, and the disturbance is not caused by something else. Fairly straightforward. There's no mention in here of dream material hallucinations, but it's a very common associated feature.
My favorite is at sleep onset. That would be just a narcolepsy.
Correct. Yeah. So if you're having RBD at sleep onset, not RBD, sorry, if you're having sleep paralysis at sleep onset, that suggests that you're getting into REM sleep at sleep onset, which suggests you may have narcolepsy. So the non-narcoleptic sleep paralysis is more common on the weekend. That's also more common in narcoleptic sleep paralysis.
They let this into the definition, so that like the question or
Yeah, if you have it at sleep onset, I would look long and hard for hypersomnia. Okay, Alrighty, let's see. Treatment, if it's infrequent, reassurance, good sleep hygiene, look for other sleep conditions. TCAs and SSRIs and SNRIs can be used as well. I'll usually use venlafaxine over any of these, but there's pretty good evidence for the TCAs. Nightmare disorder. So nightmares, I think everybody's familiar with. These are frightening dreams. They occur in REM sleep. Usually recall is vivid, and these are very common. But nightmare disorder has this long paragraph of diagnostic criteria here. So repeated occurrences of extended, dysphoric, and well-remembered dreams. So that's the nightmare. On awakening, the person rapidly becomes oriented and alert. So that's a nightmare. Dream experience or sleep disturbance causes significant distress or impairment as evidenced by any one of the following. So that really is the difference between nightmare disorder and just a nightmare. In kids, psychosocial stress is a common trigger. I think that's true in adults as well. But most childhood nightmares resolve spontaneously, don't require any intervention. In select populations, especially veterans, PTSD is a major issue, and nightmares are a common part of that. So that needs to be approached separately. But other medications can trigger nightmares. Beta blockers, interestingly, statins, as well as things that we know about, Chantix, SNRIs, that. And the PSG is non-specific. You're in REM sleep and you have a sudden arousal. Treatment, usually nothing. Non-pharmacologic therapies are best, but if you do go with pharmacologic therapies, there's some evidence for Parasomnia, particularly if there's overlapping PTSD, and very limited data for trazodone. More commonly, you're going to be recommending, if you recommend anything, psychotherapy, the most common of which is image rehearsal therapy. So essentially, you or the therapist walks through the dream material with the patient. They rehearse an alternative ending or alternative script to the dream. The patient practices that repeatedly, and eventually that new script gets incorporated into their nightmare and the dysphoria decreases. Lucid dreaming, not a ton of evidence for this, but there are certainly some proponents in the psychotherapy community. And the other common one you'll see is exposure and desensitization therapy, basically writing down or in some way reliving the nightmare and not re-scripting it, that's IRT, but just basically going through exposure therapy. Decreased sort of autonomic and sympathetic activation and arousal with each subsequent exposure. Cataphrenia, not a REM parasomnia, probably related to sleep disorder breathing, but this is expiratory groaning during REM, sometimes during non-REM, but classically during REM. There's some reports of successful therapy with CPAP, and anything you use that's going to relax the upper airway can precipitate this. So we're a little over, and I apologize, I got to run to clinic, but we'll just conclude with the questions. So let's make all of these open-ended here. So 25-year-old guy, history of loud vocalizations while asleep that began during childhood, described as loud, monotonous moaning noises without associated motor activity. They temporarily remit, following changes in body position and then recur. Sleep history notable mouth breathing. He has mild daytime fatigue. He has a small mandible and class 3 airway. If you were to do a PSG, which of the following is most likely to be found? Most likely. D, expiratory groaning during REM, correct. Okay. Expiratory groaning during non-REM is possible, but not most likely. And it shouldn't be inspiratory. That's different than obstructive sleep apnea. That's primarily inspiratory. Okay. Which of the following are not associated with recurrent isolated sleep paralysis? I actually don't like this question. Okay, moving on. Because you can have daytime somnolence, but if you have daytime sleepiness and recurrent sleep paralysis, you should really be looking for narcolepsy. Okay, and absence of daytime sleepiness is not part of the diagnostic criteria. Okay, 75-year-old guy, history of Parkinson's, being treated with Sinemet, here to see you for follow-up is RBD. Parkinson's been fairly controlled with current meds. He's taking melatonin 10 at bedtime for the last 6 months. Since starting melatonin, his awakenings have improved, motor activity has improved. In addition to those medications, he takes metformin, carvedilol, and drinks a couple glasses of wine daily. Based on that history, which of the following has the potential to trigger or exacerbate RBD? So, beta blockers can contribute to nightmares.
Oh, yeah, that's nightmares.
Yeah,
Oh, that's what.
but in his case, what would your other choice be? This is a tough question. Chronic benzo use, possible, although he doesn't endorse any of that. So the question is getting at alcohol withdrawal. So any sleep disruption can precipitate an RBD. Okay. Great representation of in art of sleep paralysis. Sleep paralysis demon is like kind of a meme now. It's all over popular culture. But I mean, this has been described for as long as humans have been around. But is thought to account for any number of sort of mystic experiences over cultures of time.
I read that sort of the hallucination part of sleep paralysis is because your brain perceives that your body should be able to move, so it sort of projects your body into space.
Yeah, that may be part of it. The explanation I usually have in mind is that, I mean, you have dream activity, from those parts of the brain that are still essentially in REM sleep. And the illusions or hallucinations, they're usually illusions. It's a pile of clothes is a person, or a shadow is a spider, or that kind of a thing. Those generally are conceived of as overactive REM related visual cortical activity. Well, that was a whirlwind, so sorry to kind of blast through that. But,